Good to see you. Happy Wednesday. I'll give everybody just a minute to get connected. See everyone still connecting to audio, getting their cameras turned on. It's good to see your faces if you have your camera turned on. I love seeing everyone. Glad to have you joining us today. My name is Anissa Mitchell and I'm with PMD Alliance. I'm very excited to have you joining us, and I would love if you would scroll over at the bottom of your screen and find that little box where it says chat, pop that open, and then give me a shout out. Tell me where you're coming from today. We love to see where everyone is joining us from. And also just a few little other housekeeping bits about this. Zoom is always updating things, so we got all kinds of options. You can have live transcription if you want, if that helps you. So if you pop up the box where it says view full transcription, you can pop that open. I think actually there's a little box at the very top that says live transcription, closed captioning has been enabled, and you can click on that. If you want it, you can have it, or you can hide it. You can move it around your screen. So, you know, that can be helpful for some people. I want you to feel free to chat your questions today in the chat box. And then after the presentation, we'll come back to those and review those. And I want to introduce our speaker. This is Dr. Mindy Bixby. Some of you might recognize her. She's been on several PMD Alliance programs, and we're very happy to have her joining us today. We're going to be talking about reimagining DBS care and how new technology is transforming access through their virtual clinic with Abbott. So we're thankful to Abbott for being a part of this program today and sponsoring it. So I'm going to introduce Dr. Bixby. For those of you who have not met her before through our online program, she is a movement disorder specialist in La Jolla, California. She is a doctor of osteopathic medicine. She got that through Touro University College of Osteopathic Medicine in California. And she completed her neurology residency and her fellowship in movement disorders from Georgetown University. So Dr. Bixby, I'm glad to see you. Thank you for joining us today.
Thank you so much. Welcome, everyone. And it seems like people are coming from all over, so that's pretty wonderful. So today we're going to be talking about DBS, and actually more specifically virtual DBS. Super exciting. It has really changed my clinic moving forward for people that are away from me from La Jolla and able to take care of these patients in all aspects in their homes. And so it's pretty exciting to actually know that this therapy is ready for more of a virtual way for people that just can't get there, or ultimately just want to stay home being programmed with their DBS. So we'll be talking about an overview of Parkinson's disease, and then ultimately going into talking about what DBS is, and then talk a little bit more about the virtual platform that is available to you now. And so if we can start the process, I would love to start the presentation, please.
All right, and that is our cue from Manuel, who is with Abbott, who is sharing screen for Dr. Bixby today.
Well, hello, here we go. So we're talking about living your best life with DBS therapy. And so next slide, please. So today, again, what we talked about is ultimately a review of Parkinson's disease and its symptoms, how it's diagnosed, and some of the motor symptoms that you may be experiencing and non-motor symptoms you may be experiencing, and how DBS can actually manage some of the symptoms that you're experiencing with Parkinson's disease. Next slide. So as we all know, Parkinson's disease every aspect of Parkinson's disease can happen to a lot of different patients, a lot of different people walking around this earth. And so the typical onset is usually ages 50 to 65, but I have had the youngest onset was at 24 years old. And so it's a really large range of people, but a lot of people that come in to see me are around 50 years old to 65 years old. The first symptom is variable. It can be anything from tremor to stiffness to slowness to aches in your arms and shoulders, and ultimately leading to a dystonia diagnosis, which ultimately gives you Parkinson's disease diagnosis. It is slightly more common in men than women, and there's no social or economic or geographical boundaries that allow you to not have it or have this. And so, and hereditary is about 35% common compared to idiopathic forms, which ultimately can happen with anybody. And so please, next slide. So what causes Parkinson's disease symptoms? So many of you know that Parkinson's disease is diagnosed by knowing that you have dopamine deficiency. What that means in the basal ganglia, which is what is shown on the right side of the screen, is there's an area of the brain called the substantia nigra, where the basal ganglia is located. And what we find on this side of the screen is on the top level, you'll see this bright commas, and that's ultimately your dopamine receptors, showing that that patient doesn't have a dopamine deficiency. On the lower area, you can see this little bit of dots, maybe a little bit more highlighted on the left and the right. And that's ultimately what would be diagnosed as Parkinson's disease, which is a dopamine deficiency. So ultimately, over time, people start losing their receptors inside the brain because the dopamine is not active as abundant as someone that doesn't have Parkinson's disease. Again, there's a combination of genetic and environmental factors that cause this or create conditions like this. And we can talk about that a little later at the end. Next slide. So what are the hallmark motor symptoms of this disease? Usually patients come to see me when they have some type of movement change, whether it be rest tremor on one side or a feeling of just slowness of movements on one side more than the other. Or you may be experiencing stiffness or pain in one area, whether it be the arm or leg. And some people ultimately change the way they're walking, where maybe their arm's not swinging on one side, or they're shuffling a little bit with their steps, or their posture has changed. And that's the time usually when people start to see me, when they ultimately see some type of movement change, where their doctor says, maybe you should see a neurologist or a movement disorder specialist that can evaluate what you're experiencing. Next slide. There's some non-motor symptoms. Again, this is not an exhaustive list. There's a very large amount of different things that can happen with non-motor symptoms, meaning not the motor symptom involved, such as fatigue, sleep dysfunction, acting out in your dreams, talking in your sleep. Some people just have really bad insomnia, loss of smell. So again, there's 3 cardinal symptoms that happen maybe even 10 years before you have any motor symptoms. And those are constipation, lack of smell or decreased smell, ability to smell, and acting out in your dreams. So those are the 3 things that I have seen in the past that can happen way before you have the motor symptoms of the disease. But you may be having them now or experiencing none of those. And so again, some people can have weight loss, and some people believe that the reason why weight loss happens is because you're actively moving much more than you normally would with the rest tremor, or you're actively stiff, which ultimately also generates a little bit more energy to be used. And so you can see weight loss, but many other things as well, which we can talk about after in the Q&A session after this talk. Next slide. So how would you manage Parkinson's disease? So when you first meet a doctor that ultimately gives you this diagnosis, you can evaluate that you have Parkinson's disease by evaluating if you have dopamine deficiency. And many times that is given by giving you a medication that gives you dopamine. But once you have the diagnosis, there's a lot of things you can do to help yourself. One is diet. We talk about diet a lot because your gut is very much involved in Parkinson's disease. They call it the Parkinson's disease gut. And so ultimately, sometimes you can have constipation and decreased ability to metabolize certain types of foods. Some people call it gastroparesis, which is slowness of the gut wall, just ultimately not allowing your body to actually metabolize your foods as easily, as quickly as you would like. And so diet is really important. What you are, what you eat, and that's absolutely true no matter who you are and what you have. And so we do make sure that you be thoughtful about what you're eating on a regular basis. And what I ask you to do is water every single day, all day long. And ultimately, because that keeps your brain and your body happy and ultimately allows you to get rid of waste and also function very well. I tend to say be thoughtful about processed foods and sugars, because that can be quite hard on your gut and your body and your brain. Exercise, move it. You have to move it or lose it kind of idea. So it's really important that you exercise every single day. Why is that? Because you want to make sure you tell your brain what you want to feel and how you want to move. And so you can get stiffer and slower and sometimes have more tremor when you're not exercising on a regular basis. So I think I've said this many times, the physical therapist is like my other arm. If I don't have them, an occupational therapist and speech therapist as part of our care, I think we're missing out on a huge component of actually getting to a better place. And so regular exercise, aerobic and anaerobic, are very, very important. Medication management, that's where I come in, ultimately figuring out what works best for you. So medication management is different for every single person that walks into my office, or who I talk to virtually, or I talk to them on the phone. Every single person is going to be different with what you're on and what works well for you. That's why it's really important that you have a movement disorder specialist at least once a year to evaluate what's going on and how you're doing, because we're on the forefront of understanding what's there for you in regard to medication changes and ultimately all the new things that are coming out. And so it is really, I think, important for you to see a movement disorder specialist at least once a year. But if you have a great neurologist, ultimately they know a lot about this. But again, I think it's important that you have a good person in your life that's managing your medications and they hear you. And it's super important that I feel that you have an opportunity to have a partner in your health. And the medication management is really, really key to feeling great every single day. Advanced therapies, which we'll be talking about today, which is DBS, is one of them. They're ultimately has changed leaps and bounds people's lives, ultimately if you're the right candidate. And so we'll talk a little bit more about that in just a moment. Next slide. So what is Parkinson's disease? Again, we talked about medication categories. There's several different medications that are available and more and more and more to come. Ultimately, what the goal is to give you back dopamine. And so I believe that if you can advance the slide a little bit more, I think it gives you a little bit more information. Okay, so ultimately what this is you're seeing two neurons and they're talking to each other. And there's a synapse, which basically is where the neuron spits out the neurotransmitter to allow it to talk to another neuron. Let me give you an example. Let's say I want to move my arm. So when I want to move my arm or my hand, there's a signal that allows one neurotransmitter to spit out or basically push out dopamine to allow the other receptor to hit and allows you to move that arm. It's so quick and fast, but ultimately if the dopamine levels are low, you can't get that signal across as quickly or as efficiently. And so when you have Parkinson's disease, dopamine deficiency, you tend to use dopamine as a supplement to actually keep the balance nice and happy. One of the options are levodopa, carbidopa-levodopa, which helps with dopamine supplementation. Next slide. There's also a dopamine agonist, which ultimately shows you it's a look-alike drug that gives you the same opportunity to look like you have more dopamine in the system. There's also something called CMT inhibitors, which ultimately are for liver enzyme to decrease the amount of breakdown of dopamine. And then there's also other ones, which is monoamine oxidase inhibitors, which ultimately stop the breakdown of your naturally occurring dopamine and also the dopamine that you're giving supplementation wise. And then we can talk a little bit more about that if you needed. So this is something that may happen as time goes by with Parkinson's disease. And as time goes by, you may notice the medication's not working as well as you'd like. For instance, if you use your one tablet 3 times a day, you're going to need a little bit more for the same benefit as time goes by. It's motor fluctuations that happen over time. And some people you've never experienced it off and on times, but as time goes by, you may experience where you have that sweet spot where things are working quite well, but it may last only for 2 or 3 hours and then it dips and you don't feel as good or the tremor's not as well controlled or stiffness is not as well controlled. And then you're going to need medication a little bit more earlier, or you may need a higher dose. And so that's something that I try to do my best to help give you a nice open bridge as time goes by so you're not getting those fluctuations. But sometimes they get a little bit harder where you may have a dose failure as time goes by, where you take the medication and you wait and you wait and you wait and you don't notice any difference, where it doesn't change. Like I swear I took the medication. You look on your box and you're like, okay, I took it, but it's still not working. And that's called a dose failure. And that can happen for a number of reasons. And also sometimes it stops early and you're waiting for it to kick in and it kicks in, but it only lasts you for 1 or 2 hours. And that's when you change the medications and you find your way in regard to getting the best possible outcomes. And so you feel good every day. But when it becomes too hard, meaning that the motor fluctuations are you never know when they're going to happen, then we try to figure out another way of helping you move forward in your life in a good way. Next slide. So I wanted to show you a little bit more. Some of you may not know what on and off time is. And so this lovely man was gracious enough to allow us to video him. And so if you want to turn up the volume, can you hear it? This is a man that's on. He's running back and forth, smiling, saying hi. And then when he's off, this is how he looks. And so he does have some tremor on the right lower hand, and also he tends to shuffle a little bit more. And he wanted to show you what he feels like when he's not on medication or when he's off. And then he also gets, when he starts his medication, sometimes he gets something called dyskinesias. And dyskinesias, as some of you may know, is when you take your medication and you get overstimulated. And so it either can happen when you just take your medications. You can get this almost like a dance-like movement. He has it in his right arm. He's trying to control it. And that happens when he's taking his medication. Once it kicks in, it becomes much more of a dyskinesia, which is ultimately the dance-like movement that you're experiencing and you see on the screen. You can also have this with wearing off, interesting enough. Very small amounts of people, percentage have wearing off dyskinesias, which ultimately that's why Parkinson's disease diaries are so important. So we can kind of know what's going on. Is it on dyskinesias or off dyskinesias or both? And so that's just a good example of just one person that has on, off, and also has dyskinesias. Next slide. So off time can happen anytime, like we talked about. Michael J. Fox did this amazing study, which 3,000 people were involved with this study, and showed that about 90% of patients have some type of off time, whether that be when you first wake up in the morning and you haven't taken your medication all night and you wake up stiff or slow or have tremor, and then once you take your medication, it kicks in. Some people have it where they wear off before their next dose, and that's where we try to figure out what's working for you. Again, Parkinson's disease diaries are super important. The other thing that can happen is ultimately having a dyskinesia, where you have experiencing abrupt ons and offs and some dance-like movements like we showed on that video. Next slide. So how do we optimize on time? We talked a little bit about that. So I think it's really important that we have to understand that as time goes by, it's not that the medication is not working as well as it did. And that's where I feel like some people feel that they don't want to start medication early because they're worried that they don't get the opportunity to wait until they absolutely need it. And what ends up happening is they did these studies where they found that patients that started it early on compared to later on, it's the same amount of time where the medication has motor fluctuations. Why is that? It's that your body and your brain is losing dopamine over time, very slowly, but it is losing over time. And when that happens, you need more supplementation so that you can balance the amount that you're losing. And so that's why you end up having to do a little bit more medication as time goes by. And so as deficiency grows, you may have to figure out how to find the balance in regard to how much dopamine you have on board. And so the idea is doing the best you can with what you have in regard to every single person is going to be different the way they fluctuate, and if they need different medications based on the fact that they want to keep the optimizing of the on time. And so the whole idea is getting you to the best possibility moving forward. And so that's why it's so important to talk to your doctor on a regular basis so we get you the best scenario so you start to feel better. Next slide. So I think that's a great caveat into talking about deep brain stimulation for Parkinson's disease. What is it? Why do we choose to consider doing this for you? And why, as a partnership, we decide to move forward and make this happen. So let me talk to you a little bit more about that. Next slide. So we have, so next slide, please.
Oh my God.
Is it too much for you?
No, I'm good.
Okay. This is stimulation on, and again, we'll talk more about what deep brain stimulation is off right now.
Turn the right DBS off, which controls the left side of your body.
Okay. And we're waiting for the DBS.
I can't believe this.
And she has had
Okay, please put the mat on.
period of time she didn't know how
Oh
to
my God.
when she didn't have the DBS on. So it's a beautiful way of understanding. Okay, it really does this amazing thing where it ultimately allows you to have basically electrical. So this is her on.
You're back on.
Look at that. This is amazing.
That is amazing.
It's incredible. One of my favorite things is to see somebody's face after they've gotten DBS and what profound change they can have that's with you all day long, every day, because it's part of you. And so it does reduce the involuntary movements, the dyskinesias, because you can modulate the amount of stimulus that you have. You can't do that with medications. You take it and then you have to wait till it wears off. And so the beauty of it is that you have an opportunity to be able to do that. And I always give my patients that choice as time goes by, where they can modulate that when they need it, go a little bit more up on the dose of stimulus compared to another time when they don't need it. So I'm going to talk a little bit more about this because I think there's a lot more to be said. And so deep brain stimulation is this. So what happens is that there's a lead that's placed inside the brain. It is a brain surgery, so I want to make sure everybody's aware of that. And what they do is they put in a lead that's probably about maybe 10 hairs thick that goes inside. That's something what we talked about, the basal ganglia, where the dopamine deficiency is. And what it does is it stimulates. It allows you to actually have an opportunity to modulate what's happening inside that area, so you get the best possible scenario in regard to getting to a place where you're taking care of the deficiency without overriding the things that actually happen in the system when you have a dopamine deficiency. So ultimately the lead goes in, it's underneath the skin, it tunnels underneath behind the ear into a battery pack, like a brain pacemaker. Like I'm sure some of you have seen a pacemaker for the heart. It's the same kind of idea. And what that battery pack has is, so there's all that information that we're doing to help you to actually program you. And again, a lot of different questions I know are going to come up right now, but ultimately what it can do for you with DBS is it can lower your amount of medication that you're on, which ultimately will lower your side effect profile of the medications that you're experiencing. And so a lot of times I go down by a half, sometimes even down to 2/3, depending on the patient and what they need. You never go completely off of medication because of the fact you need it for the non-motor symptoms, which we'll talk about. Next slide. So DBS, again, perfect caveat. What does it treat? So it treats stiffness, slowness, tremor, dyskinesia, because ultimately you don't need as much medication, and ultimately helps you with an overall importance of a lot of the cardinal symptoms that you have with Parkinson's disease. And so again, it's really important that you talk to your doctor if there's something that you're maybe considering, so that we all know what exactly is your goals. What is your goals for DBS? And if the goals are to improve tremor and slowness and stiffness and overall dyskinesias, this may be the right thing for you, because those are the things that for sure the FDA has approved to slow or decrease the amount of symptoms that you have with these 5 that you see on the left side of the page. Next slide, please. This is also really important for us to talk about. DBS does wonderfully for the motor symptoms of the disease, but it cannot help the sleep dysfunction. Again, I have seen some people in the past get a little bit more louder, because as you know, with Parkinson's, sometimes you can have a lower tone of voice or difficulty getting the words out loud. Speech dysfunction is something that they cannot say that DBS is going to be absolutely responsive for. Swallowing, again, if it's a swallowing motor apparatus, it's always a question that maybe it will help. Micrographia, which is ultimately smaller writing, can be helped sometimes with DBS, but we can't say for sure. Sometimes it's less responsive. Postural instability and falls and freezing, absolutely can't say that it's something that will be helpful with DBS. But again, we have to know when we start talking about DBS together, what is our goals? What is it that we feel that may be helpful with having this on board as a treatment management tool for you? It's ultimately, we just have to make sure we're doing the right thing for you. And again, the right candidate as well. So what happens if we go, yes, I think this is a great thing for us. I think this will be really great to help you for your Parkinson's symptoms. Ultimately, you have to be a good candidate. We have to know that what you're trying to help is stiffness, slowness, tremor, and the dyskinesias that you may be experiencing. We also have to say, okay, how is your cognition? How are your thought processes, and how are that going? And a lot of times we do a neuropsychological testing just to make sure that we have a baseline understanding of how you're doing, both with mood and also with cognition and short-term memory and thought processes as well. So we make sure that we're doing the right thing for you with the DBS. Next slide, please. So let's talk a little bit more about the Dbs procedure. This is a lot of questions for people. And again, if we want to, we can show the on-off again with this, that's fine, and see a little bit more about what can happen when you're on it.
it turns off, and you will see that the tremor begins to return to my right side. It affects both my hand and my leg, and is quite violent as a result of the DBS being turned off. When I try to do the testing that they always do, my left hand works fine, but my right hand is out of control. Same thing with my trying to touch my nose, or if I flip my hand back and forth, as I'm sure you've already tried yourself. The activation of the unit puts us back on, and you can see the cessation of the tremor and the calming effect it has on the rest of my body.
Incredible. I mean, I know, go ahead and next slide.
I feel it right away.
Thank you. And so it's interesting how many volunteers we have that want to be a part of these videos because it's changed their life. And so for the right person, it can really impact you in a beautiful way to allow you to actually do the things you want to do on a regular basis without worrying so much about the medication wearing off, or when you're going to turn on, or is the tremor going to come back all of a sudden. And so it's nice because you have a little bit more control when it comes to managing your Parkinson's disease. And so this is a picture of showing you kind of how it works. Again, the stimulator sends electrical pulse to the lead, and ultimately the lead delivers a stimulation to the targeted area depending on where we decide to place it, usually a Parkinson's location target, and then ultimately it stabilizes the brain signals that cause the involuntary movements. And so it's pretty incredible technology. It's been around for quite some time, DBS, and I've been programming and talking about this for some time because it is a wonderful therapy for the right candidate. Ultimately, it can definitely change your life. And as you can see on the bottom, that's your little battery pack, which we may have another picture of. Can we advance the slide, please? So again, this is talking about staging, just because I know a lot of people may have just questions about what we do and how we do this. First and foremost, we have to make sure that you are the right candidate. We go through the neuropsychological testing. We ultimately also do an on-off evaluation in the office with a video, seeing if what you look like off with no medications on board for at least 8 hours. And then we evaluate you again on after 1 hour, giving you the dose that you're usually on. And we evaluate you first off and have a scoring system called a UPDRS, which gives me from 0 to 120 of a number of how you're doing. So it's kind of like golf. As you swing, the more swings you get. So the higher the level, the more Parkinson's symptoms that you have. And then giving you the medication, an hour later, we evaluate you again and see how you feel and see how you look, and ultimately seeing if you at least have a robust response to dopamine replacement therapy. And if you do, you are a good candidate in that regard. And so those are the things we do before we even go to this step and say, okay, let's talk to the neurosurgeon, let's get a consultation and see if you are a good candidate. We go through all those steps. And then when you do decide to go through DBS, this is called the stage 1. So ultimately there's imaging and planning and evaluating your brain, because all of us are a little bit different from each other. So we want to make sure we get the right placement. There's an implant of the lead while you are either awake or asleep. And we evaluate you by asking you if you are awake. Some of the symptoms that we're looking at for tremor, we watch the tremor and we actually stimulate different areas. And if it calms it down, we know we're in the right location. Again, we also use a lot of parameters where we look at your neurons firing, knowing that we are in the right space as well. And then that lead is secured, and then the opening is closed. Next slide. For stage 2, what happens next is they run a lead and extension to a battery location down in your chest. Again, and then they connect that stimulator to and check the system, making sure everything is working well. and then they implant the battery and they close the area. So again, it's usually below the clavicle, as you can see there, depending on what side. Some people have bilateral battery packs. Some people only have one-sided battery packs where both sides of the leads go into the battery pack. Next slide. So after implantation, just so you know, probably about 3 to 5 weeks after you get the batteries, we evaluate you and initially program you. What does this mean? Ultimately, you come and see me or whoever is your doctor, and you spend probably about 2 hours with them. And what you do with initial programming is you do not take dopamine replacement therapy on that day, just because you want to make sure that your body is nice and clean of anything else other than the DBS that is going to be programmed for you. And so you usually do not take medication for at least 4 to 5, sometimes a whole day before you actually do the initial programming. I usually do it very early in the morning, so you feel the best you can possibly feel. Again, we do the mapping of the leads. What that means is we ultimately look for the sweet spot. You have 4 contacts on the lead where there's 4 different possibilities of giving you the sweet spot and making you feel like you have less tremor, stiffness, and slowness. And then we choose the best electrode contact location for how well you look that day. And again, and then you do an initial, after that, maybe 2 to 3 to 4 weeks later, we do an optimization where we find just the, we tweak it a little bit, giving you the best possibility moving forward. And at that point, usually I adjust your medications early on so that you have the right benefits. So again, go back to initial programming, no medication on board. We do the DBS initial programming. After that is done, I usually start you on medication, a lot of times half the dose, depending on the person again, and I have you go home and you feel how it feels to be programmed for that day. Again, sometimes you're a little tired on that day because you're running a marathon doing the programming. And then a couple of weeks later, we evaluate how did it go? And we talk about it. And again, a lot of times I talk to my patients within the first couple of days, even at the day of, and see how they're doing based on what we did for them. And then we follow up and we optimize it to the best possible scenario for you. So you start to feel really good with your control with tremor, stiffness, and slowness. Next slide. So everybody, I'll ask this because it's important. I mean, what is the cost and coverage of DBS? So most public and private health insurances, including Medicare, cover and approve DBS, including for Parkinson's disease and also something called essential tremor. And so if you're concerned about the therapy coverage, ultimately you need to talk to your insurance company, but I don't think I've ever had a difficult time having this covered for a Parkinson's disease patient, which I think is wonderful, 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 because I think at some point, hopefully this will become standard of care. But at this point, most public and private insurance companies will cover this for you. Next slide. So side effects, again, we have to talk about that. Very, very low side effects, but again, there are always a risk, especially because it is a surgery. There is a risk of when the lead is placed that you can have other neurological symptoms, including strokes and opportunities for that when that lead goes in for things to happen. So we need to be aware of that. And again, we talk about the risk and benefits of DBS, and it's very, very, very low risk for that. But again, you need to talk to your doctors about this as a possibility for you based on what your body has been through. Ultimately, you get a cardiac clearance and make sure that your heart is good and your lungs are good and everything's good for you to actually go through through the surgery. But it is the first line therapy outside. First line therapy is medication, but surgical treatments are also available. Again, knowing why you're doing this for somebody, what you're looking for, what your plan is, what your goals are for DBS are extremely important to talk to your doctor about. I actually have a very important discussion with my patients where I have, let's talk about 3 things that you hope that will get better with DBS. And we write those down, we both sign it, because we want to make sure when we first start this journey with each other that we have the right ideas in mind. And so we know that what this DBS will do to help you, but also know what it won't do based on what we've seen in the past and also what it is FDA approved for. Next slide, please. So let's talk about Abbott. So Abbott is an Infinity program system. Ultimately, why we're here is to talk a little bit more about virtual. So DBS has been around for a very long time, and I've been programming for quite some time. And it's been such a wonderful tool for a lot of my patients to help manage their symptoms. Now they have this opportunity to have a virtual platform. What does that mean? So for me, I tend to complete the first programming together in the office, just simply because I want to teach you everything. I want you to feel comfortable with everything. But ultimately, a lot of times after that, you can be programmed at home, in the comfort of your own home. So ultimately, they have now a platform where you can use your cell phone to help guide and allow me to actually program you from home. So it's pretty amazing. And as you can see on this slide, it shows the lovely iPad that I'll be working with and seeing your wonderful face on. And then the battery pack, which is what you see on that silver area. And then again, seeing the doctor in that picture, which would maybe be your cell phone. And then again, that's a bore lead, and that's the lead on the side. So next, there you go. So a bore cap that secures the lead in place. Again, once they open up the skull, they have to have something there to actually place it there and keep the lead in place. Next slide, next. Number 2, that's the stimulator that powers the system, like we talked about. 3, an extension to connect the lead to the battery. And then the 4th is the clinician program, which I just showed you, and the patient controller, which you can see. And then the lead implant in the area of the brain affecting the movement is ultimately what you see, and there's little contacts there. So this is a great, I love this, this video, if you can get it to start working. Ultimately what it's showing is that's where the sweet spot is. And as you can see, there's contacts all the way around. There's 4 of them. And the beauty of this directional lead is there's 2 areas where you can actually move the stimulus just a little bit to the left, to the right, lateral, front, and ultimately get the best possible scenario for somebody without having the side effects that some people may experience when it's stimulated. So it's really wonderful. So there's so many more therapeutic options now than they were even like 3 years ago. So things have changed so dramatically with DBS, and I'm so excited about it. It's been pretty amazing. So how would you experience care that supports your health and fits your life? So ultimately there's freedom. The battery life is quite good. And ultimately when you go and you're free, you get to a place where you get to a control of your daily life. So I give you an opportunity to actually change the system when you need it based on your symptoms on that day. After we program you and you get to the sweet spot. The nice thing about it is also that there's an opportunity for you to actually do this from home. The virtual platform has changed a lot of people's lives because a lot of people don't live close to me to go in and get programmed on a regular basis, or they want to travel somewhere and they want an opportunity to be able to be programmed somewhere else that is not close to home. And so that's really changed the impact of patients feeling like they have to stick close to their doctor when they want to travel or do things that they want to do, or they just simply can't get into the office because maybe it's a little bit harder for them to move around and get going, or they need somebody to take them here. It's just nice. And I truly do love, it almost feels like a house call for me. I've always wanted to be Doc Hollywood and be able to go to everybody's houses and say, hi, nice to see your home, see how you're doing in your natural environment. And this has given me an opportunity to do that for a lot of my patients, which is really exciting as well. I definitely believe that virtual is here to stay. Next slide. So I think we talked about this, that you can have personalized access to therapy, which is wonderful. And you have an opportunity to be able to learn, very easy platform, extremely easy to actually use, very user-friendly. And again, you'll be taught everything about this, of course, if this is something that you would choose to do. But it's been a great way of actually helping us connect with people that couldn't otherwise get here on a regular basis. And so it's a great opportunity for the right candidate is to manage your Parkinson's disease with both medication and having this opportunity to have this with you all the time. So the on-off is not as apparent all the time because you have something with you working for you all the time. So I think that's the end of this talk, but I want to make sure we have open it up for questions because I'm sure we have some.
We do. Actually, one that just came in, I'll go ahead and ask that one, then I'll go back to some of the other ones that came in. This person wants to know if someone already has a DBS or got it a while ago, is there a way for them to get access to virtual clinic?
Yes. So there's now, we're able to, because it's stored in the battery pack, we have actually work on that in regard to changing the battery and making that available for them. Yes. Please talk to your doctor.
So I want to go back to symptoms for a second.
Sure.
Someone had asked, they think that they might be experiencing dose failure. So if this is happening, is this something that even if their physician hasn't brought up, that they should then approach their doctor as an option for them?
Sure, absolutely. So let's talk a little bit more about how to manage, how this goal today for this clinic or for this presentation was to let you know that there's more things out there. And so, and as we talked about the opportunities to change and manage your medications, there's a lot of medications out there as well. There's so many things you can do to actually improve your outcome in everyday life. And so DBS is something that is known across most movement disorders platforms. What I do, just so you're aware, is I actually talk to patients about all the options, and they may never need them, but I think it's important for you to know that they're there. And so if you're having on-off times and medication is not really doing the trick for you anymore, or you're having more offs and ons and they're just really sporadic, sometimes medication management, you can make it a little bit better and get to a place where it's working well for you. But sometimes it's a on-off on a regular basis that you don't know it's going to happen. Then DBS may be a really good option for you to help you kind of get to a place where you can take several steps backwards in a good way, back in time, and say, maybe you don't need as much medication anymore because the DBS is working for you in concert with your medications to feel better, and you're not having those off times anymore. So definitely ask your doctor about it, because I think it's something it's part of a standard of care of Parkinson's disease. And I think that everybody should at least be discussed about this as a possibility.
So earlier, someone wrote in, a friend of theirs had DBS about 6 months ago. She's having difficulty with her programming. Basically, it doesn't seem to help anything except her dystonia. Have you had any cases or experiences with an issue like this?
Oh, of course. I mean, again, there is a possibility for anything. And so sometimes you just need a reset and say, okay, how well is the lead? Is that sweet spot the best sweet spot for you? That's why we have to continue to kind of work with people what are your goals? And so dystonia is one of them. Stiffness, slowness, tremor, you may be experiencing. And again, I can't talk on your individual medical record and helping you, but I can give you an overview of what we usually do when that happens. Is that if it's only helping with dystonia, there may be a different contact that's a little bit better for you to work with other things that you may be experiencing. And so there's something like 15, I can't even tell you how many possibilities of programming there is in regard to finding the right one for you. But ultimately, sometimes you can actually change the programming and do quite well. And again, depending on how long you've had it and all the other symptoms that you may be experiencing, I kind of want to understand a little bit more about what you're wanting to improve. And again, if it's slowness or rest tremor, there is a way to actually maybe program it a little bit differently so that you get benefit with both dystonia and everything else.
Awesome. So a question just came in that I think is a great tag on to that. What if the unit has reached upper limit values in one region of the communicator? Should the value be raised or lowered to avoid the message?
Okay. So I would have to probably look at that and see why that's happening. So I have a feeling that I know what you're saying. So there's upper limits to how much stimulus you can give based on a mathematical model and parameters of the actual system itself. And so sometimes you have to use different ways of using it. And again, that's when I believe, which again, we didn't talk very much about, but the leads changing and having directional leads where the lead itself can actually give you more information and more power and benefit without using too much power, by using a little bit less power and getting the same benefit. I know this is good. I don't want to confuse everybody because it's a lot of information if I could show it to you, but the idea is that there's several parameters that come into programming. And so the beauty of it is that now we have directional leads. You can use less power, less pulse width, less frequency, to actually get the same benefits, so you don't run into those issues.
Awesome. We had a question about depression and DBS listed as a side effect. Now, is this new depression, a new onset of depression?
Okay. So you're having more depression now that the DBS is placed, is what I think I'm hearing.
I think they're wanting to know is, can it cause it if it wasn't there before?
Usually I have not seen that as a clinical trial evaluation of there's more depression in patients that have DBS compared to not. It just depends on situation. So it's a hard question to answer because it's not been tried and true shown that placing a DBS causes depression. There may be a situational reason why that's happening. And again, if that's the case, or if you feel like there's a feeling of doom when you get programmed, then it may be that contact may not be the best contact for you. But actually placing the lead itself has not been shown statistically significantly to cause a mood disorder or a mood change.
Great. And should the unit be on 24/7 or not? This just came in.
Great question. And so when it comes to Parkinson's disease, the Parkinson's symptoms that are still there when you're sleeping, not moving in bed and certain other things like the rest tremor and is not there. There's a certain area of the brain that goes to sleep, which doesn't cause you to have tremor while you're sleeping. But if you're just about to wake up, the tremor will be there, and that's sometimes why people use it 24/7. So I tend to have patients use with Parkinson's disease, use it all day long, 24/7, just because of the fact that there's other symptoms that it's helping you, even if you are sleeping. And so I think it's important that you keep it on.
All right, we had a couple of questions that came in regards to activity. So one person wanted to know if there's any exercise modalities you can't do with after implantation, and another one wanted to know if there's any limitations after implementation.
No, there's not. I mean, again, when it comes down to this, so people like, well, I have this stimulator in my brain. I can't swim anymore. I can't surf anymore. I can't do yoga anymore because for fear of making the leads not, they're very bendy, if I want to tell you, and they're very, very much tested, tried and true. So I have patients that haven't been able to surf. I live in California, that now that they have DBS, they're able to do that now because now they're able to paddle out. It's pretty amazing. Swimming and all those other things, yes, absolutely. You can do any of those things. It's a closed system inside the body. And so please continue to do all the beautiful things you do before DBS, but hopefully better with DBS. And so it's not an issue with what you can accomplish. It's ultimately gives you an opportunity to be less stiff, slow, and tremorous, hopefully, based on what you have, to improve your actual exercise ability. So there's nothing that you cannot do. Again, I do say if there's a really significant, like really bendy, wanting to do pretzels, is that good for you in a yoga pose? And I've never had anybody have an issue, no matter if they're contortionists or they're surfers or they're really large swimmers or they're weight builders. All those things are ultimately okay and wonderful to be able to do with DBS, and hopefully you'll get better at it with opportunities not having stiffness, slowness, and tremor.
Well, this next question seems like the right question to follow that is, do you see an improvement in stamina in your patients with DBS?
Yes, depending on what their Parkinson's symptoms are. So yes, so I've seen a lot of people have much more ability to kind of keep on pushing through because their symptoms are not modulated or managed by just medication. And so this is always there helping you, hopefully. And so when that happens, the medication may be wearing off, but the DBS is still in there. And so you're able to actually do things longer and with more gusto, I can imagine, if you have an opportunity to have multiple treatments and multiple management tools.
So again, in regards to activities, this person wants to know if it's a problem to change amplitudes throughout the day, depending on what they're doing. So lowering it for yoga or a different activity.
So what I usually say is it depends on the person for one thing. If they feel like they really kind of lose out on a lot of dopamine when they're exercising a lot, which can be vice versa. People feel like, oh, I have more pump up and I feel like I have more dopamine in my system. It just depends on the person. But yes, some people modulate it based on what their activity is. And sometimes when somebody, for instance, emotions can really get in a way, more tremor, more stiffness, more slowness, because when you're stressed, sometimes it can make you have more of it. So I have people that go into social situations that they normally would tremor quite a bit. They just increase the amplitude a little bit, and they actually are able to control it a little bit more than if they didn't do it. And so I think it's a great way of managing your symptoms. I do also say that I don't want you to go up and down all the time, because you won't know what your sweet spot is and you won't know what works well for you. So sometimes at the beginning of the programming and for the first several months, I say, let's try our best to kind of keep it the best we can where it is, and then just do minor changes so that we kind of truly know what's working for us and what's not working for us.
Awesome. So I have a question in regards to the process. So you mentioned earlier a neuropsych evaluation to rule out maybe cognitive changes. Are there standard screening procedures for this? Like, does every movement disorder specialist and neurosurgeon go through a standard process? And are there other team members that are involved in this process other than neuropsych?
That is such a great question. So a couple things. And so it's not standard of care to get a neuropsych test, just so you know. And a neuropsychologist is who does that test. And it's sometimes between 2 and 5 hours of a testing evaluation of cognition and depression, mood changes. And so not every center does that. And so some people actually get something called a Montreal cognitive assessment, which is also known as a MOCA, which can be used as a screening tool as well, based on the ability to have a neuropsychologist available, ultimately what the patient is experiencing at that time, and also the questions that we have in regard to mood. And if that's if you're having mood changes, whether it be anxiety or depression, you have somebody on board that's helping you, or you're well managed, whether it be medications or therapy, or you feel like you are doing well. It actually just helps us kind of understand a little bit more about what state of being you are before the DBS, so that if there's anything that does come up, that we can kind of see a baseline and understand where you are prior to getting DBS. The other people that are part of this, I ultimately also have physical therapy. I have a nurse practitioner that is the off-on testing. I have a neuropsychologist, which works very closely with us and understands Parkinson's disease, which helps us tremendously understand about red flags or things that may be normal for somebody that has Parkinson's, which some people have apathy and some people have other things that they experience that are pretty normal for Parkinson's disease, but not necessarily going to create a difficulty or deficit for us to actually get DBS done. I also usually tend to have physical therapy, occupational therapy, speech therapy available always, because that's part of what helps you kind of move forward in life and make sure that we have the right opportunity to help you. And then of course the neurosurgeon is a part of it. And again, their team as well. So there's a lot of people that are involved with DBS and making sure that you get the right, perfect situation for you if you choose to go in this direction.
And I had a question also about the telehealth part of it. So do you need to make an appointment to do the program? Is it billed like a regular telehealth visit? And and I know I'm asking 3 in 1, but I'm just trying to make it as simple as possible.
Sure.
And is there any concern in the future of insurance not covering telehealth visits?
Those are great questions. So first and foremost, you usually set up a visit just like you would with a telehealth visit with your doctor. I don't know exactly if you've done that in the past, but we have quite a bit of people that have done the virtual platforms for just a normal follow-up visit. And then it's billed as a follow-up visit, but it's also billed as a DBS programming visit. And at this point right now, Medicare and all the other insurance companies are covering it as if you were in the clinic with me. And so I do not know the future. I'm hoping that for the unforeseeable future, or we'll always be able to do this based on the fact that it has been it changes the quality of life for patients. And we are constantly lobbying for this to be available for both virtual visits as a follow-up and also through the virtual platforms for them always to be available. I don't know what I don't know at this point, but I know that at this point it's been very clear that they have approved it up till the unforeseeable future for us to actually allow us to do virtual moving forward for hopefully ever.
And I had a few people ask earlier, is this surgery reversible?
So the reversible part of it is that, yes, you can always take out the lead. It is something that has been really thought about for a lot of patients because there are some new ideas of ultrasound guided lesioning for Parkinson's disease. They used to do where they take out an area of the brain to help patients that have Parkinson's disease that is not used anymore that I know of. This is one indication where it is reversible. If you choose that it's not working for you or you're not happy with the system, you definitely can take it out, and there's no issues with that in regard to taking it out and creating any other harm in any way. Ultimately, they just take the lead out, take the battery pack out, and then they no longer have DBS.
And I'm sorry, going back to programming, because there was another question. Can someone get treatment virtually from a physician licensed in another state, but not where they live? Again, maybe they don't have access where they live.
That's a really great question. So that's kind of the goals moving forward with a lot of the movement disorder specialists, hopefully very soon, is where they do have an opportunity to do virtual programming out upstate. The biggest issue with that is that that doctor does not have medical privileges in your state, and that may be difficult. It is something where I've thought about very more than you would ever know over the last 5 years of how to get access for patients that need that. Again, there are, okay, so there's, I'm so sorry. What'd you say, Manuel? Can you please say that out loud? I didn't read that. I just read something about that. So in regard to, there's a license pact where you can go, you can cross over virtual borders or natural borders of states to actually help patients that are not able to get to your state for programming. And so in time, I believe there's going to be opportunities where there's pacts with movement disorders where we can actually program certain states based on our medical licenses. So we're working on that every day.
All right. So a couple more questions. We're almost at the end of our time, but someone asked if DBS is recommended for a person with Parkinson's that does not present with tremor, but has more stiffness and dystonia.
Okay, so can you say that one more time? I'm so sorry.
Or is it recommended DBS for someone who doesn't have a tremor, but more of the stiffness and dystonia?
Absolutely, absolutely. That's yes, that's probably about 25% of my patients. And so you don't have to have tremor to have a diagnosis of Parkinson's. A lot of people believe that tremor is the cardinal symptom, but some people only have dystonia. Some people only have stiffness, and it's definitely FDA approved, and it's helped quite a bit of patients that have that. So yes, absolutely.
And then another person asked, should they even have off time if they have DBS?
So you could still have off time because DBS doesn't completely control all your symptoms. And so depending on how, because your medication and your DBS are a marriage, they work together in concert with each other. And so a lot of times the DBS can do only up to 80%, and you may be actually getting a little bit of benefit, which again, I know for sure you need a little bit of dopamine replacement therapy to help you modulate and help you manage your disease. And so, yes, you can still have off time with a DBS. That's why medication is also part of your care. The goal is that there's much less off time. And as time goes by, again, remember that those neurons are still losing dopamine, and you're losing dopamine over time. And so sometimes you just may need a little bit more of an amplitude change, or a little bit more programming, but again, or maybe you just need a little bit more medication to keep that nice bridge happening so you don't get the dips throughout the day. And so it's just, again, it's a personal question, because knowing you and who you are and what you're experiencing, your doctor will be able to help modulate that so you actually don't have off time, which is the goal.
Awesome. Well, I am so glad that you joined us today and gave us such a great overview of the symptoms for DBS, but not only that, but the system and the virtual clinic, which is really amazing and really does help people to receive this benefit, even if they live in a rural area and they would have to drive in hours. That's huge. So that's really important.
It's so wonderful. I mean, it's so funny to think about this opportunity to be able to do this in a virtual platform. It's incredible because there's so many people, and again, in California, everybody's driving from everywhere. And so having that opportunity, even just to not have to get your clothes on, get in the car and come and do this, you can do it at your own comfort of your own home, which I think is pretty amazing. So I think it's changed a lot of people's ideas of choosing to do DBS because now they have this option. And I think that I've seen leaps and bounds people deciding to go forward with it just because they have this option of virtual. So it's pretty awesome.
And that virtual thing is really important because the programming can go on for how long?
It depends each person, but the first visit is usually a 2-hour visit. But normally I give a whole hour to program. It may not take that long, but we talk about everything else. We do almost like a virtual evaluation as well for medication management and how you're doing. And if you're exercising and you're drinking water and you're doing all the things you need to do, I get to do all of that in one visit, which would normally take almost an hour or longer. And also driving in and driving out, I mean, that's another 2 hours out of your day. And so that's the cool thing about this. And also it's helping everything in regards to the population of traffic and everything else. It's just so nice to have an option like this. It's pretty amazing.
Absolutely. Well, Dr. Bixby, thank you so much for joining us today. And I know that everyone is grateful for your time. And if you all want to save the chat, just in case you missed the link and you want to be able to get it, I'll just highlight that all you have to do is go over to your chat box, over to the far right where the little 3 dots are, where it says more, you click that and you can save your chat, because I've had a few people request that. So in the meantime, I would love it if everyone would be willing to give the wave of gratitude and thank Dr. Bixby for her expertise. And I also want to thank Manuel and Abbott for this program today. And we look forward to seeing you all again very soon. Dr. Bixby, thanks so much.
Thank you. Take care. Bye. See you.
Bye.